welcome our next team to talk with us about behavior as communication. So Katrina Davis is actually going to do the introduction for Dr. Sorensen, but I also want to just take a second here to remind us all that we are well aware of the broad spectrum that we serve, and that the broad spectrum includes many who have profound needs. And so I don't want anyone who's listening to think that any of us in echo autism are blind, submissive, or dismissive, any of those things to those real, raw, powerful, important needs. And like I said earlier in my opening comments, we look at this as a longitudinal opportunity. Every year we do our symposium. Every year we are doing thousands of hours of professional development for numerous people around the world and different types of professionals. And so I would say it's on all of us to better understand the breadth of the spectrum. And so with that, I want to turn it over to Katrina. She is going to introduce again Dr. Sorensen, and then Dr. Sorensen will share her content with us.
Thanks, Kristen. Good morning, good afternoon, good evening, everyone. My name is Katrina Davis, and I have the pleasure and the honor of introducing our next presenter, Renee Sorensen, a clinical psychologist who specializes in the assessment and treatment of children with neurodevelopmental disorders and severe problem behavior. Renee joined Cincinnati Children's in 2000 and has focused on providing intensive intervention services across multiple settings. She has developed home-based ABA, or applied behavior analysis programs, community consultation to schools and agencies, an intensive severe behavior treatment day program, inpatient psychiatric stabilization for acute crisis management, and is currently the co-director of the behavior safety team who serves patients admitted for medical care who have pre-existing behavioral challenges or who struggle to tolerate their care needs for any reason. She has received several local and regional awards for her important and effective work. So as I mentioned, I'm Katrina Davis, and I serve as a family advocate resource specialist with a successful and expanding Echo Autism program in Washington State. We were so inspired by what we're seeing coming out of Echo Autism at University of Missouri Healthcare and across the country. Well, we joined the wave, and we're seeing some impressive outcomes here in Washington. My colleague Jim will put a link in the chat if you want to see what we're doing way over here on the northwest coast of our country. So I'm the proud parent of a 24-year-old profoundly autistic young man who experiences the type and intensity of dysregulation we'll hear about today. I'm a vocal and persistent advocate, and I had discussions with Kristen Soule and Alicia Curran about challenging behaviors, which we all know are distressing for parents, for families, those of you who serve this population, most of all, for the person experiencing the acute behavior crisis. I was pleased when Kristen asked me to introduce Renee today and to provide some opening comments and framework about behavior as communication. And I had a really nice, compelling conversation with Renee as well. My comments will take about 4 minutes. So in addition to my ECHO work, I am also a crisis case manager at Seattle Children's Hospital Emergency Department, assigned to our profoundly autistic IDD population in chronic behavior crisis, those whose extreme behaviors exceed what parents can provide safely in the family, home, and in the community, and they end up in our emergency departments. This often means they're stuck in our emergency departments because the necessary services up and downstream are limited or often non-existent for this population, and they're unsafe to return home. Unfortunately, sometimes they meet discharge criteria by our definition, and they're sent home unsafe, sometimes over-medicated, to overwhelmed aging parents, only for the traumatizing cycle to repeat. Or worse, and I see this a lot, parents have no other choice but to seek out-of-home placement, away from home, family, community, and all they know, because at least in our state, we do not have the long or short-term therapeutic inpatient facilities or residential placement options for this population. Is this happening in your state? I'm sure it is. And I just want to say congrats to Ohio for having Renee and her team. It is really a national model. So behaviors communication, a window to help us determine the root cause of the behaviors, right? And in some cases, our most profoundly impacted autistic adults or people, children, teens, and adults, the behavior is often a manifestation of the disability and not an intentional naughty tantrum that warrants a timeout. We're talking about the intensity of behaviors that result in self-harm, harm to others, that requires medical attention. And I've seen this more than a couple times in my career at Children's, headbanging that resulted in detached retinas and irreversible blindness. We're seeing unsafe bolting into traffic or water. That drowning and accidents are the #1 cause of death for our profoundly impacted autistic population. Property destruction that can result in families being evicted or denied stable housing. These behaviors are real, they're happening in family homes, and our current home and community-based services are really missing the mark. And we are witnessing the unethical outcomes that result when we don't address the often very different service needs for this population. For a non-speaking or limited communication, intellectually impaired population, sometimes we listen differently, as our previous speaker just said, and we figure out the trigger for the extreme behavior. It might be pain or hunger, or maybe they want something they can't express what they need or want. But sometimes we can't figure it out. It does not mean we stop trying, but it's important to acknowledge that we might never know the reason. I say this because when we put relentless pressure on parents to figure out the reason for the severe behavior, we run the risk of making them feel unsuccessful or incompetent, which impacts their confidence and self-worth. Hallelujah when we identify the trigger, and with quality interventions and expertise, like we're going to hear about, we often do. But when, despite our best efforts, we can't crack the code, it does not mean the parents or the autistic individual, for that matter, are failures or didn't try hard enough. Lastly, sometimes parents or family members are discouraged or shamed for sharing the difficult realities of the dangers and harm of these dangerous and harmful behaviors. We understand these are powerful and very hard descriptions to hear, and it's painful for parents like me to talk about it. We hold our loved ones' privacy and dignity in high regard. We don't like sharing their most difficult moments in their lives, but we have realized remaining silent is not benefiting our loved ones. If system leaders, decision makers, elected officials don't understand the magnitude of this problem, how will they know what to fund and how to build the appropriate services? And hopefully the type of programs and supports Renee is going to tell us about. Now, take it away, Dr. Sorensen.
Thank you, Katrina. For a great introduction, but also just setting up some of our most severe situations that we see. And I see this all the time in my work, unfortunately, but it's what I signed up for and what I want to do. And I truly love and value working with individuals who are really struggling, and the care providers who are trying to help them from all areas. If these slides aren't sharing appropriately, let me know. So as we set up for today, I'm going to talk about behaviors communication. 45 minutes doesn't cut it. So it's going to be a high level overview, and also going into just the way we standardly approach behavior and how we think about it, but also a little bit more in depth when the behavior is so severe and it isn't treating the way we think it should. And since I work in a medical center, I hear a lot of people who, when it comes to any person with autism, any autistic individual who is really struggling, and they're doing basic workup to try to figure out if they can understand why, if they can't find something pretty quickly. And again, we can't, we're just not running a lot of MRIs and wide variety of things. So it might be some basic workup, some imaging if there's a place we know how, where to look at, maybe, because we don't do full body imaging typically to start. Some blood work that might look okay. We can't figure anything out. The symptoms are just really hard to identify because maybe we don't have good communication to be able to figure that out. And so it is very common to go, well, it's behavioral. So these are the things that families face all the time. It feels like blame when those words are stated, and it feels like I'm not doing enough. And so trying to get, I've been at the conference all day. I have loved all the communication and the movement is coming and embracing this diversity and getting people to understand the whole person and see them as a complete and whole individual is such a foundational and wonderful movement forward. And I think there's been so much good work done when we get into really, really severe behavior that is causing significant damage. And I have seen traumatic brain injuries, and I have seen, detached retinas and subdural hematomas that are mild. They range mild to severe to a true TBI. I have seen broken bones. I've seen cracked and broken teeth. I've seen families just mauled with their arms. And so we're talking about really, really challenging behavior. And we have a lot of knowledge, but getting it to come together in comprehensive treatment is really challenging. And so I'm going to run through basic treatment approach, but also kind of get into when to think about bigger picture. And one of the things we do, I work at Cincinnati Children's, and one of the things we do there, we have a team that is dedicated to working on any child with any kind of a behavior challenge. But my training is in developmental disability and autism more specifically, and I have focused my entire career on this population. And so getting people to understand that behavior, let's not call it a problem, let's call it just a symptom of distress. So this person is in distress, and that behavior is a symptom of that distress, and we have to figure out what is causing that distress. And sometimes we can get really severe problem behavior that the person does not look distressed at all. That might be running out in the street or running into a pool of water that is highly dangerous, but they think it's fun, but don't understand maybe the safety risks. So there's a wide variety of behavior that can occur here, and I've used a variety of ways to describe it, but we're really looking at behavior that is a challenge to keep a person safe or to keep the people in their vicinity safe is what I'm really mostly referring to. So I'm not really referring to, we've had people who like, I want to treat, I don't want my child to hand flap, and that isn't something that I would take on. It would be something that I would more coach to. What is the regulation they're getting from that to help them cope with their situation? And maybe there's things we can think about around that, but I wouldn't put them in a big treatment program for that. So what we need to do for when we want to change behaviors, we really have to understand both the environment and the internal conditions that might be contributing to that challenge. And I think also setting the stage, because when you work like in a hospital setting where we have a whole bunch of people there to care for mostly children, but also some adults who maybe don't have any behavioral background or training. Unfortunately, nursing and regular physician programs don't have a lot. We are pushing for more of that, but it's slow to come. And then we provide it in our hospital, but they get bits and pieces and it comes along the way, but it takes a while for people to incorporate it. So if you have somebody who's having behavior that scares you, it is really easy to personalize that behavior and think they're doing it to you or because of you. And so that doesn't help us work with the population either. So really, really trying to help people recognize this as distress and move forward. And in doing that, then we take away that blaming because I do see a lot of blame that still occurs in our in all of our kind of treatment environments. And most of that blame occurs when the provider or the person or the professional, the nurse or, the related specialist is not as familiar with autism, or does not, just doesn't know what to do and is frustrated by like how to figure it out. And so deflecting the blame is really a coping strategy that they employ, not to harm the person, but to kind of relieve themselves of the stress of, I don't know what to do. So it's a really complex situation. When we look at the history of understanding behavior, Brian Iwata was key in this, and it is behavior analysis. And I know there's a broad base of feelings about ABA, and that I am broadly trained as a psychologist, but also specifically trained in behavior analysis. And so when he developed what we call the functional assessment, and it was an analog functional analysis, he was able to actually identify really specific conditions where self-injurious behavior was really communication for very specific things going on in the environment. So he developed what he called these primary functions. And there's been a lot of research on since those preliminary articles were published in that work. But it still lays this really good foundation that is still super helpful when we're treating challenging behavior, especially severe challenging behavior. So those 4 functional behaviors are actually universal. They're not specific to autism. He did most of his work in developmental disability, so it wasn't just autistic folks. And so, and this, you can apply this to your children at home, your husband, your wife, your significant other, whoever is in your family. We can look at behaviors and kind of lump them into these categories. So escape is just, procrastination, trying to get out of things we don't like, avoiding it. We can do these in really appropriate ways and very inappropriate ways. So our goal is to teach people to do these, to get this need met in an appropriate way versus using severe challenging behavior to get out of those things. Same thing for attention or relationship seeking. We might have a child at home, neurotypical, who is a class clown and loves to get attention and might even get a little bit of trouble doing that. But we can also have individuals who don't know how to get attention other than to use really severe situations. I have a young man yesterday I was just working with, and he is autistic and he has a trach. And he loves being in the hospital. He is an adult now, and he cannot find a day program that will support him because of his medical needs. And so it's been a real challenge. His mom is lovely and she supports him, and he has staff, but he doesn't have a day program, and he really misses all those people. So when he comes in for his medical care, he hates to leave because we all love him, and he gets lots of good positive attention. And so leaving is a challenge for him, and it makes me sad, but he will actually pull that trach out, pull his G-tube out, and do all sorts of things to try to prevent himself from going home. And those are kind of attention seeking behaviors, and also just, I want to stay kind of a thing. I want to avoid leaving. It's a kind of multifunctional, but if we understand the distress he feels, where I don't want to be home, I'm stuck there a lot, I don't get out as much. It's really heartfelt in terms of what he's going through, and how do we help him get a better, robust set of circumstances to help him have a good quality of life, so that the hospital isn't where he seeks his quality. Anyway, each of these individual things can be broken down, and it makes it really simple and simplistic. But I don't want to say that that's the end all be all, but it does provide us this really good foundation for situations where I can look for what's a pattern of a child. So give another quick example. I had a adolescent that I worked with who came in with his self-injury was so severe, he'd almost lost all the skin on his face. He was completely raw, and he did end up developing cataracts and later a detached retina, even with good quality treatment. And we did find out he had some other comorbid things going on over time. But anyway, when he first came to me, he was not able to even go in the classroom. He couldn't get in anymore. So it started with, he'd go to class, he'd have demands placed, he would have a big outburst, they would take him for a walk, he would calm down, they would go back, they'd do the same repeat. So every time he had an outburst, they took him for a walk. And so you can see how this would quickly develop pretty soon. He's learned pretty quickly, if I have an outburst, I get to go walking. So then pretty soon he started having behavior before he even entered the door to the classroom. And later they weren't even able to go down the hallway that had the door to the classroom. And he had just kind of shaped up the staff to basically say, I can go to school and walk all day, and that's all I'm going to do. And then I'll go eat, and then I'll walk some more. And so they couldn't get him in any functional way in the school. And so he needed treatment to help him get over that. So we worked on that. And his primary function then was escape. He had all sorts of things going on, but that was the primary thing he came in for. So we use this mechanism to help drive kind of what we have to do. And we had to teach him that actually doing work isn't a hard thing, and learning is a really good thing. And we had to kind of undo that heavy desire to avoid any learning environment, which we accomplished. And I still see him as an adult. Sometimes he has a lot of medical conditions too. That also made his fuse short, I'm sure. But when we think about how this behavior develops in that situation, it was very learned, right? And it was just, he had frustration, unmet need, didn't feel successful, maybe wasn't interested, a lot of things. And so when his frustration was expressed and met with, let's take a break and go for a walk, through that trial and error and learning, he learned that a significant tantrum will get me from having to go back to the classroom. And so when any behavior, positive or not negative, is followed by what the individual wants, it is likely to increase. Okay. And we know this in our daily life, and we do this. It's also what we do. So typically, as communication and appropriate skills or adaptive skills, social skills, behavioral regulation skills, coping skills, as all those increase, which hopefully there's education going on all along the way, problem and challenging behavior, distressing behavior decreases. However, it doesn't always happen. And when it doesn't, we have to look at that more comprehensive assessment, and they may need more individualized treatment to address those concerns. So when we go to figure out the function, the very specific experimental analysis I mentioned with Brian Iwata, we can do those in really intensive clinic settings and treatment settings, and they work for a certain population of individuals, but it doesn't work for everyone. It's not appropriate to put every person through that kind of a rigorous assessment. And sometimes we can actually just interview, and we can figure it out. We can look at the situations. We can talk to a variety of people, including the person who's struggling. And if they are non-speaking or don't have a good communication system, then we rely on their caregivers or the different people across their environments to answer some specific questions, to potentially collect some data, and really looking at, where are these challenges occurring? What situations do they occur and not occur? Do we think we have an idea of what they were seeking, what they were feeling, their level of distress? Are they healthy? Do they feel good? And then how do they respond? Did they get what they want? And does that resolve the behavior? Is there any place the behavior never occurs? All of these things give us information for how to proceed, right? So common things per function, these are just pretty simple. It's not an NLBL list. I'm just giving an idea for those who are not as familiar with functional assessment. But if you have an escape motivated behavior, we say typically there's some kind of a demand that's in place or implied. So the child I was talking about who didn't want to go in the classroom, either a demand was placed in the classroom that he did not want to do, was not comfortable with, or even later when he approached the classroom because he knew the demand was implied, it was coming. So then it kept starting later. I have had many school-age children who get to the point where they won't even go to school. So that is an escape motivated behavior that might start for a situation in the classroom and then expands all the way back to I'm not going to school. Tangible behavior is typically when they can't ask for or negotiate for what they want or need when they have the iPad and it's going to get pulled away. Nobody warned them. They don't have negotiation skills to say, when can I have it back? I need more time. And all of those communication nuancing negotiation skills that may not be developed doesn't mean that they don't have those thoughts and feelings and that's what they want. So we really have to understand it's really hard when somebody's always managing your stuff and you feel like you have no say and control and ability to figure out how that's going to be navigated back, even though you have those desires. So it becomes this really challenging situation, and we have to do a lot of teaching around that behavior. And then attention-seeking behavior, I also call this relationship-seeking behavior. But again, sometimes when kids get bored, they will do things that just try to rev up the world. Sometimes it is more of when somebody's talking to somebody or talking about them as a key thing. When their caregiver is busy, and this is pretty universal for all kids, right? So when do your kids need you? When you're in the bathroom, when you're cooking dinner, when you're on the phone. And if you have autism, you're no different. It's very similar. Or when there's withdrawal of attention, we see some folks are really, the attention is very important to them, yet they might not have the social skills or this reading the social cues in a way that is robust enough to help them navigate that, right? And then automatic is anything internal. So common triggers for those types of things is, again, if we're bored, we might start doing more sensory-based activities. And if we don't have a lot of play and leisure skills to fill need, we fill that with often sensory. And sensory can be fine. It can be wonderful, but I've had sensory play be playing with spit or sucking on my fingers so much that I have complete skin breakdown and get cellulitis. So it really just depends on the level of the behavior. And it's not to say that every sensory difference in autism is a problem at all. It is really to say, when does it become a problematic behavior that puts them at risk for other situations? And then we put pain in that lump, lumped into as a trigger for an automatically reinforced behavior as well. So a person might have an ear infection and start hitting their ear, which might diffuse the pain from the significant inner ear. To provide them a little bit of actually comfort, which I would think that's not going to provide comfort, but we see kids do lots of different things when they hurt to divert that pain in different formats. So those types of things can cause challenging behavior. And then again, when this behavior gets reinforced, that's when it continues. So if they have an escape motivated behavior and we stop that demand or change it, delay it, it goes away, that can reinforce the problem behavior. And sometimes it's very appropriate to do that. So I'm not saying that we should never do that, but we really have to understand how our response to the challenging behavior might reinforce it. And if I'm going to get a child to go in the classroom, then I can't take him for a walk every time he doesn't want to be in there. But I can change it so I can make it appropriate for him to escape appropriately, and we can put some parameters around that. Same thing for tangible. If we just give them what they want when there's a big tantrum, that is going to tend to get more challenging. Same thing for attention. If they get big reactions and that's what they like, if they like a big, strong reaction, we have many of the kids I work with do not seem bothered by a strong emotional reaction, and they might actually even laugh or giggle a little bit. Does that mean they think it's funny? It depends. I don't try to overinterpret that, but I consider that it looks like there might be some reinforcement going on there. So we have to think about how we respond to a behavior so that we don't make it worse. For example, my young adult who pulls out his trach, typically several people come running when you pull your trach out because it's a little bit concerning medically, right? But we have to coach everybody to be super quiet, one communicator. Do you know what I mean? Whisper, make it as both medically urgent and non-reactive as possible, because he really, really will keep going, and it just will create a lot more different things. If we give him that strong reaction, he'll try to keep seeking it, and it might even go into other aggressive behavior that is self-directed or directed towards others. So we have to handle it very specifically so we're not reinforcing that problem behavior. And then again, any automatic reinforcement is internal, so we can't control that environmentally, but we can learn about it and then try to replace it. So when we go to design the interventions for learning kind of what this behavior is communicating, we have to take the time to understand their skills. So how do they communicate? And if there is no communication system, we're probably going to need to start working on one, but it might be very simple. It is not true that every person can learn, one set of kinds of communications, right? I know many families who've tried all sorts of communication strategies with not a lot of success. And so we really have to look at that individual, their strengths, what's been tried. And then sometimes we go back and try again because your brain continues to develop. And while you may not have been ready at the age of 6 and 7, 14 or 15, you may actually be ready to try that again because you've learned some prerequisite skills. So again, we never stop trying, but we really have to think about communication is key. I don't just teach communication and behavior replacement, but it is key because even if I do some other replacements, if you're sensory seeking, and I'm going to replace your sensory need with an appropriate way to get it. So I may not want you to suck your fingers, but we're going to give you, if that's an oral stimulation, want other ways to get oral stimulation so that you don't get the skin breakdown. Or if you like wetness on your hands, we're going to give you other ways to get that feel that won't, again, cause the cellulitis and the skin breakdown. But over time, I'd really love it if you can communicate for those things when you want versus the adults around you having to anticipate those for you, because that is just going to continue to build that good quality of self-advocacy that we want to see develop. And we have all sorts of outcomes with that, but my goal is always to get anyone there. But we also want to think about their current behavior regulation and coping. We might have to work on some of those, how they learn best. And again, it's not every child with autism or autistic person has a visual strength. Sometimes it's auditory. Sometimes we need to go different routes. And that's a huge myth in the field with learning styles, where everybody wants to, teach everybody the same way, and it just doesn't work. Again, your baseline sleep and how you feel, your activity level, do we have mismatches that we need to address in part of that treatment, et cetera? And then what do you like? Because I'm going to build on that and see if we can build on those current strengths and your likes and build towards the quality. And then we want to teach skills that are foundational and have a direct impact on that behavior, especially if it's a problematic behavior. But sometimes we have to take steps, small steps to build. So it takes a little bit to get to something that's going to impact the behavior pretty robustly. And that can take some significant time and work. And then again, we have to keep thinking about, is this person healthy? Because those are always in the back of my mind when we have really severe behavior. So quick overview of this behavioral treatment. We're going to identify that function. And again, it can be multifunctional. And then we're going to think about the environment and can we modify anything to help and reduce triggers and stress. That does not mean we can take away all triggers, right? I can't take away the fact that you need to learn and go into a learning environment. So, but I can think about how we do that. So I can make those learning situations super small, heavily reinforced, build confidence and success, and then build you up over time to tolerate a longer and longer learning environment so we can get you back in school. So again, those are all environmental modifications that help us think about that. And then I'm going to teach replacement behaviors and skills. Hopefully that's also going to blend towards communication over time, but where the communication comes in really depends on the individual. So behavior is communication, but I can't always start with teaching you communication to reduce your problem behavior. So we have to think about that carefully. And then extinction, we really want to make sure we're changing how we respond so that our reactions are not reinforcing the challenging behavior that we're trying to reduce. Because if we're reinforcing the challenging behavior while we're trying to build the other skills, it takes a lot longer to get somewhere. So we have to consider that component. And that's not punishments. That's just really trying to reduce the reinforcing method. So how we respond to a behavior might be more therapeutic, quieter, calmer. It may feel a little less supportive. So like when we the young man with the trach, when we go in there to replace his trach, we are kind and we try to be supportive, but very quiet, not a lot of eye contact, but the touch is gentle, and, we're not, we don't have to jerk around or be mean to him at all, but we just have to be real quiet and careful in how we interact. And that is because he really likes everybody to talk and everybody to be wild. And he will chuckle through that. When we do it really quietly, he's like, that's kind of boring. So our goal is to bore him into having better behavior. And then we want to make sure we're reinforcing the behavior we want him. So we're going to, for him, we're going to reinforce lots of, once we get him stable and he's moving forward, we're going to reinforce all sorts of positive interactions and good things. And then we're working on how do we help him cope with those transitions and look forward to what he's getting at home and have knowledge of that kind of things. With our behavior management, we can't expect a miracle, right? It takes a while to change this behavior and distressing behavior. And you can't just reduce a behavior, you have to build skills that replace it. So that takes time depending on the level of skills that you're working with and what you need to replace. And different environments are able to support different levels of intervention. So you have to look at the whole context across. And then safety. So we talked about individuals who have really severe behavior that might cause significant injuries to themselves or others. And that all has to be built into how we treat, where we treat, and where this goes. When the behavior is so very severe, this is the approach I still take, but I'm already moving on to what else do we need? Because behavior that is so highly distressing is typically rarely just a skill building issue. And when there's a sudden onset or change in frequency or intensity, that just makes my ears stand up when a parent will describe that, because typically I'm like, okay, what's going on? There's something else, that has changed that individual's fuse. They've gone from a longer fuse to a really short fuse. And so what is driving that? And we all know that when we don't feel well, we're going to be more crabby or respond differently than we typically do. So a person with autism is no different. And so any of those, anybody who's had a really high, has had good access to quality treatment services, and they develop increases in behavior, or behavior's just not going down, or they're really struggling, I'm also going to go, that's just not, typically kids respond pretty decently. And so if they're not, we may be missing something and we have to look further. So we want to keep treating, but we want to also broaden our look, right? So when we've had strategies that are effective and then they stop working, again, we're like, well, why did that change? So maybe a function change and we have to switch our treatment approach a little. That's fine. That can happen. But sometimes it's something else is going on and we have to look a little bit differently. Whenever I see regression of skills and habits. So if they stopped eating and they used to eat really well, or, their sleep has changed dramatically. Toileting, see that I lost my G there, but toileting habits, if they were toilet trained and then they start to have accidents, that is going to make me look more specifically into those kind of situations and what could be driving that. And, eating might be strep throat, it might be teeth, it might be, the GI system. I mean, it can be a whole variety, but we're going to look all the way down the body to see what we can find. Same thing for sleep. It can be a sleep disorder, but it can also be a mood disorder, and it all can also be reflux. So when I lay down at night, my reflux is active. I wake up agitated. It disrupts me several times a night. There's a lot of things that can occur. So we really start to gather a lot of different information about how behaviors have changed and what is being seen, and then that helps us guide those interventions or looking for a broader array of challenges. And then when we start to see challenging behavior that occurs during highly preferred activities, and again, if the highly preferred activity is an iPad and it locks up, that makes sense. But if you are watching your favorite movie and then you have a blowout tantrum and nobody can figure out why, typically there's something else going on in the body. And so we really have to look in depth to see if we can figure out what's going on and are there any other clues across the day. Many years ago, we had people using that functional analysis kind of environmental design and really starting to show that individuals that might have a different behavioral response when they had treated and untreated medical conditions. So that started to pop up in the literature to really show that these untreated medical conditions could really change rates of behavior, right? So lots of demonstrations there early on. And then as we've expanded, the co-occurring medical conditions that we now diagnose in everybody, but that show up a lot in autism, it continues to grow. And I feel like when I started 25 years ago, when I left my fellowship, it was an occasional medical concern, and now it just seems like it's super common. So most of the patients that I treat that have really severe behavior, I feel like have co-occurring conditions. And so I'm always queuing into that much more quickly than I used to, which is why I'm spending some time on it. And I shifted all my work eventually. I've done many, many programs, but I've shifted all my work now into the medical center because of this issue. We had so many kids going for behavioral treatment, and what they needed is medical and psychiatric treatment that was, and behavioral treatment, but it was really hard to get access. And so because their behavior was so severe, it was hard for people to manage them. So I finally went and said, well, let's build a program so that they can get the care they need, so that they stop pouring into psychiatry when they need medical care. And so we've done that, and we've had a lot of success, but they keep coming and we keep seeing it. And now we have lots of kids who come in for really regular care because they can access it and they can access it safely. But we're learning more and more about what can co-occur. And then there's the psychiatric conditions. So mental and behavioral health conditions, again, more common in autism. And I will tell you, I get frustrated as a clinician when a child comes to me and in their chart, there's a list of psychiatric comorbidities that's this long, because people have just kind of attached these diagnoses willy-nilly across as they come in. And really it's trying to sort out, we know they have an autism spectrum, they're on the autism spectrum. And then what are the key, maybe these key additional co-occurring conditions that might be driving the behavior versus giving them everyone, known to man that aren't going to be all that helpful. And again, it evolves over time for sure. But I think that's something our field needs to do a lot better job of, is really trying to not just slap things on as we go, but really looking more specifically and making sure that we're not, if we're replacing one, trying to really pull out the other and make sure that's well explained to the family, and not just slapping things on kind of willy-nilly, which I still see. So when we see behavior that isn't responsive to traditional therapies, again, we have to think about those both medical and psychiatric co-occurring conditions. I always like to rule out medical conditions to contribute to distress kind of first. And when any patient comes to our emergency room, they get a medical rule out before they go get their psychiatric evaluation if behavior is the concern. And we have improved and improved and improved. I feel like initially, 25 years ago when I started in Cincinnati, if they came in with behavior, it was behavior, and people weren't looking at, were you constipated? Did you have strep throat? Like, were there other things going on? And they've gotten so much better really doing a medical rule out. And that's not that they draw labs on every patient. I mean, if they're not having symptoms and that the family isn't worried about pain or something, but they just feel like they've had some other changes or truly stress, having major stressors maybe that have impacted the whole family's coping. They don't have to necessarily do that, but they're more likely to they're going to ask the questions. Are we having normal bowel movements? Have we had any change in urinary continence? Are they eating okay? Are they drinking okay? And going through at least those basic things and checking the ears and looking down the throat, and doing a nice rule out. And we have people to support so that they can get those rule outs before they go on. And then it takes, observation of symptoms and a good evaluation to diagnose and then effectively treat. So really, looking at those is super important. And then I mentioned when we get the really severe levels, so we are seeing more catatonia in autism than we've ever seen before. And part of that is I think that we're recognizing it, but the other part is I think that it's also increasing. And so I just got notified before I talked today that there's a young guy in the ED, and he came in for a psych eval, but they are actually thinking catatonia might be it. So he'll come medical first. We'll do the stabilization medically, and then he'll go over to our psychiatric unit typically after that. And I know his name, and he's been in before. And you learn a lot watching kids evolve and how catatonia evolves over time. And then we've had some of our patients be so severe that they've actually needed ECT. And we have some access to that in Cincinnati, but we're needing to build more access to that because we draw from a wide region, and we're getting a lot more treatment refractory behavior, and they've had really good behavioral treatment, really good medical treatment, really good psychiatric treatment, and they're still really, really struggling. And again, these aren't families who have failed these kids. These are really, really challenging kids and young adults who need a really comprehensive approach. And so it's not just behavior, it's really, really complex distress that these individuals are going through. So another thing that comes up a lot is behavior pain-based or is it behaviorally based? And I both love and hate this question. I like it when it is posed as a question because it's making us consider all of the options. Is this person who does not have a well-established communication system, and we might have a high pain tolerance. Are they uncomfortable? And how do we figure that out? And so it's really important for us to pause and ask the questions about how are they when they're healthy? What does that look like? And what is this difference? So that helps us know if you have a baseline behavior that includes chronic challenging behavior, how is this behavior different? And that helps us look at it both medically and psychiatrically. But we have to really understand that discomfort reduces coping for me and for you and for pretty much every human that I know. And you're more likely to have an increased behavioral reaction when frustrated if you're uncomfortable. And so we still want to treat during medical care or if somebody's hurting. And this is a thing I coach families on all the time because they'll come in and their child is found to be sick. And we certainly adapt behavioral intervention to illness, right? I'm not going to expect you to do the same level of activities and things that I might when you feel well, but we still want to make sure we don't just give in to everything. Even though that can be what my heart wants to do, we do find that sometimes then the behaviors don't go away as easily, even when the individual feels better. So it is really important to continue what I tell parents is you got to still parent through the illness to help keep things on track so that we don't go backwards behaviorally. Because once you're well, we want to make sure we're moving forward in the right way. And I'm having this conversation right now. We had she's an adolescent autistic adolescent who needed numerous cleanouts, and she was, and they're tough for her, but she came in really sick and she ended up being diagnosed with colitis. And so she got a lot of treatment for this infection, and she's going to need ongoing kind of support and care for that. And so GI is very involved with her. And she already had a very limited diet, but would eat a variety of what I'd call kid-friendly foods. But she had a nasogastrous tube, and she was both cleaned out, and then she got nutrition through that. Which she actually tolerated because she was so sick, and she's gotten better at tolerating that. And then as they started to introduce food again, she really wanted chips. And so her mom was giving her chips, but it got to the point she was eating like 11 bags of chips a day because she just got really stuck on chips. And so, and then she didn't want other food. And so to help her be more open to other foods, we need to get rid of the chips. But mom was like, but she's sick. I just want to feed her what she wants. But I'm like, it's not nutritionally sound. And there's a lot of things. So we've been having a lot of discussion because the longer you go of just feeding her chips, the more I'm afraid she'll be stuck on just wanting chips because she has that, she tends to have that really intense interest in things that can really persist. So anyway, it can take time to tease these things out and kind of keep needing to keep up and follow up. For pain, when we're talking about it, it's really critical. We can't always use the same pain scales in the medical environment. So we may not get the grimacing. We may not get a person who can communicate pain reliably. And I've also seen where we've had individuals who use like a picture exchange communicate pain reliably with their picture system, and it be discounted because it came through a picture system. So, you know, as providers who are well-trained in this, we really have to advocate to our colleagues to say this is robust and they are saying their pain. And if they were vocalizing that out loud, how would you treat them differently? So we really have to educate. But we really have to think about, does it, you know, do you have a normal tolerance for pain, or does it seem to be high? And a lot of parents will be like, I'm not sure. And so then we can just ask a variety of questions to tease that out. So how do you know when they're uncomfortable? I don't. Okay. Have they ever had an injury that you think should cause discomfort? Yes. Okay. All right. And how did you know? Well, I saw it and they never told me. Okay. So they probably have a high pain tolerance. So that's what we'd call that. But it might just be that they didn't understand like how we kind of categorize. So having those conversations doesn't mean a family is not aware. It just means that they may not have actually had anybody ask them that before. And so if I have kids I work with who have had broken bones, but they were found haphazardly versus them showing or even limping, I know they have a high pain tolerance. And if they can tolerate that and walk on it and get by, then, you know, I might even have the question of, do you experience pain and how is that safe? But the other thing is, if you do, how are you going to show that? So what we often see in high pain tolerance is they don't express low levels, and it's like a flip is switched. And I've had many autistic adults tell me, absolutely, who can vocalize can tell me, absolutely, my pain is that way. It doesn't even register in my system. And then when it does, I can't even articulate, and I lose the ability to kind of manage it well. And I need supports to help people understand what is going on with me, because they'll be like, you know, they'll think it's a psychiatric condition when it's just pain. So really, really important that we kind of understand every person's pain-based behavior when we're dealing with severe behavior, so that we can try to tease out what is what. And then with that management, it really is about, if we don't have good communication skills and it's hard to see and we know they're going to have something pain-based, we really have to think about proactive pain management. So in a tonsillectomy, they'll give you pain management right after, but then they typically will dose mostly PRN based. If we have an autistic individual come in who gets a tonsillectomy, I'm usually conferring with the families and then recommending to the medical team that they actually proactively pain manage, if that makes sense with the family in terms of their pain profile. So we also want to think beyond the medication. Again, they might not ask for the things that are comforting from a sensory standpoint, but we want to offer normal kind of pain management that we would with other folks, to make sure that we're doing the things that would help and also destimulate the environment, because most people are much more sensory sensitive when they hurt. Okay, and then we want to see, can we develop pain-based communication skills based on this? Okay, so a quick summary is when we're dealing with really severe, challenging behavior, we have to have a comprehensive approach. We have to look at the whole person. So we can't just see them as a skill deficit, right? Or a problem behavior, but we have to see them as a person in distress who probably needs to build really specific skills to help them manage what is distressing them in a better way, plus our help, right? To manage the environment, to work on that comprehensive approach. And then, are they getting the medical and wellness care that they need to stay healthy? Are they getting the psychiatric care that they need to make sure that all of those conditions are doing well? And then that treatment usually needs all of it put together to really get the support they need. And in the end, the families really typically in severe problem behavior need way more help and support than is available. We have so many services that shy away from this significant behavior because they have trouble knowing what to do and keeping everyone safe as well. And then my last thing that I'm going to share with you is this is hot off the press. So in pediatrics, there's a new Healthcare for Youth with Neurodevelopmental Disabilities consensus statement that was just put out. It was by the Supporting Access for Everyone initiative, which is a consensus panel, and I was on this panel, and it was really eye-opening and heartwarming and distressing to go through and really talk about healthcare in neurodevelopmental populations and how hard it is in this country, where we're supposed to be leaders, but it is still such a challenge for people to get the care they need. And we have some pockets of really good support across the country, but we don't have equitable access across the country. So please download that and read it and continue to contribute to that work.
Thank you, Renee. That was so powerful and really helpful. And I appreciate that link as well to that article, because again, I think that we often are so unaware of the experiences that many autistic people and their families are having in the acute care setting. And so certainly I really appreciate your talk and the ideas that you shared with us, and really the leading example that you and your team at Cincinnati Children's are doing. And so thank you for that. We do have a couple of really great questions. So I want to make sure we have time for that. So one question that I wanted to ask you is from one of our participants. Can you talk about responding to challenging behavior and assent-based practices and how this is appropriately balanced?
Consent-based, is that what you said?
Assent.
Assent.
A-S-E-N-T, yeah.
Yeah.
Mhm.
That's a great question, and it really depends on the individual. And so I like to assume competence and talk to the family and the individual who needs the treatment support, right? Because often there's way more understanding than we believe there is. If that behavior is really severe and impacting safety, assent might not be, and we always would try to get assent, but it might not be able to be got, or if they did not want the treatment, we might still have to do it if they are not their own guardian. If they are their own guardian, that becomes a different level, and we have to think about, you know, are they, do they have the ability to make that decision in that moment, just like we would for a person with suicide or other kind of behavior, or homicidal behavior towards a person. So those have to be thought in folks who are their own guardian, just like they are in the typical adult population. But we do want buy-in, and then we want to give a lot of choice throughout treatment that really brings in what every individual wants and needs. I had a parent who, she was lovely, and she had gone all across the country to help her daughter with some really severe challenging behaviors. And she ended up on our neurodevelopmental unit when I was doing psychiatric inpatient. So I'll tell just a quick story, but, and she had some speaking skills, trouble understanding big complexity, but we were able to break things down, and they were treating her in a pretty intensive ABA program that I was a little surprised at, because she had skills that were much higher than what I would have expected for the level of kind of discrete trial type work they were doing. And so when we got her in and I met her and talked to her, and I showed her actually, we had just a really solid token system that was for, just based on positive reinforcement. And I went ahead and put her on that program, and we found quickly that she got really overwhelmed in our milieu with other kids. She'd go out there for a while and do pretty good, but she needed breaks. So we just built in breaks for her, and were able to kind of accommodate her sensory needs, and where she got distressed, and encourage her being out and engaged when it was appropriate, but also allow her to take the breaks. And she just did really well. Like, she just did so well. And what I found out from the family is they had this really high energetic, everybody was an extrovert in her family except for dad. And she was truly an introvert. she was a person who she liked small doses of social, but then she really wanted to go kind of be, hang out and not be in the big, go with the 8 other kids to the soccer game kind of a thing. But we were able to just work with the family on, what she really likes and dislikes and how her personality was and her sensory needs. And what I do say sometimes is, we have to parent the child we have, not the one we want. And it's just to try to help kind of match what is this child presenting with, and I cannot make her an extrovert in your family. I can't do it. I don't know how, and I don't want to because she doesn't want to, right? So but having a conversation, her mom was delighted. She cried because she went, I didn't even think about that. She didn't mean to not consider it, but they couldn't have a meaningful conversation, and we teased it out through a whole variety of things. She never sat and said to me, hey, I don't like to be with my family at the soccer game. She showed us through her behavior, right? So I think those are ways that if I can't get a scent in a normal way, we're seeing it by how you respond to the treatment and how it looks, if that makes any sense. That was a long-winded answer.
That was okay. That was great. And I appreciate that. And I know there was a kind of a secondary question related to how do you get a scent if you can't get in the traditional ways, and who else might you involve? And so I was just going to throw in that for those of you who are in hospital systems, ethics can be a really good partner in this, and trying to figure out like ethically what makes sense. And again, I liked your point about how this is the same process that we would apply or should be applying to anyone who may not be able to give us traditional assent. So anyway, I just appreciate that, because I think sometimes we make this extra hard when we are talking about it and applying it to autism or individuals with non-speaking ability. And the fact of the matter is we do this a lot, right? Like there's a lot of spaces in our medical worlds that we have to think about assent, consent, things like that. Okay, so another question came in around a person who has a daughter who's over the age of 21 and who's not able to find or get approval for ABA-based therapy now that she's over 21. So the question was really about, does the therapy community agree and or support that ABA is not effective after the age of 21? So the question is really about kind of broad-based therapy in people older than 20, 21.
Right. No, there's no age limit on it. It is really the right match with the type of behavior analytical program and the client's needs, the individual's needs. And so behavior analysis is way more than discrete trial training. And it if it's done well, and there's a lot of cookbook behavior analytic kind of informed programs that aren't very behavior analytic. So those of us who are higher level trained, and I don't have a BCBA, I didn't go get the certification. I'm old, and they didn't honor it in Ohio, and now we've got it, and I've got folks in my program, but I'm behavioral analytically trained. And so I think that I just want to say that you do have to match even in behavior analysis, you have to match the treatment with the individual. And so it shouldn't be a cookbook cookie cutter based program that you put somebody into. But if you're doing really effective, if you really know how to do behavior analysis, it will look very different across your different populations. And so in that sense, yes, it doesn't matter how old you are at all.
Got it. Thanks. I appreciate that. Okay. Yep. I know we're really close to time, but I'm going to squeeze in one more question. So the question is, how do you lessen attention-seeking behavior when a student or person is not safe and may potentially harm others? The specific question is kind of related to a student who's a flight risk and is aggressive when not given a preferred item, in this case, a Chromebook. I know that's a heady question.
It is a loaded question. So what I always say is we may not have a specific response to the behavior, but we never ignore a child. So how I might respond to that is I'm not going to reprimand the behavior or do certain things that might feed into it. But just like our young man with the trach, like he liked everybody rushing in, right? We had changed how that looked to not reinforce that behavior. And so when you have elopement risks, which I've treated many a times, I'm usually looking, are they running away from something or to something? And so that's going to drive how I treat that. And sometimes it is truly, I want to be chased and tackled, and I think it's hysterical. And so we still might have to chase, and we might have to do other barriers and look at where we are in the building and do lots of environmental modification to try not to chase, and have a silent code response where people are going to doors quietly and blocking entry. I've done a whole variety of ways to try to reduce the excitement of the chase. And then I've also done, this child loves to run and have that interaction. And so we build in fun chase in their day. Like we go play tag in the gym and we just make sure it's a safe environment, and we teach other appropriate ways to get that. And then we build it in, and you can earn it and you can communicate for it, and we can do all sorts of other fun stuff. So it really is understanding that function. If it's attention seeking chase, we can often make that fun and appropriate, and then it reduces the need to do it inappropriately or unsafe in a more unsafe way, right? And again, we're hopefully building on what that person wants and needs. And then same thing for the Chromebook. A lot of that is, it depends. Usually that's a tangible, not an attention seeking. If that's a situation, we're usually looking at a lot of like schedules and supports, and start with maybe very small relinquishings and then gradually increasing it over time to build the tolerance for, I will survive not having my Chromebook every minute.